Thank you, respected chairpersons. At the outset, I'm thankful to Dr. Manoj, Dr. Purvi for inviting me for this topic. So it's an interesting topic because nowadays everybody is actually going for weekly things. Probably after a few days, monthly thing will come, but everything weekly once GLP. Then I am going to discuss weekly once this DP4 inhibitors. This is Trelagliptin. So, of course, if we'll discuss Trelagliptin, I will discuss about what is Trelagliptin, what is its role in diabetes, unique once weekly dosing, and what are the trials or evidences with us to support that how it works and what is the significance of that. So, you know, it's a novel oral DP4 inhibitors mainly approved in Japan, and it is highly selective T cell activation antigen on specific action CD26. So the most important thing is probably it is not available throughout the world, and it is approved in Japan and also in South Korea. Then it is recommended as add-on therapy. Which are the drugs you can add? Of course, metformin, as we everybody know, you can add to metformin. On top of that, you can see it can be added to sulfonylurea, SGLT2 inhibitors, insulin. So we have now studies it can be added to each and every molecule which is available with us as an add-on therapy. And what is the significance? That it differs from the other gliptins like citalina, that it is once weekly therapy. That is the significance, because whenever we discuss India, our HbA1c is low. One of the most important thing comes to our mind that probably compliance is one of the biggest issue for particularly Indian population, where you are adding diabetes, hypertension, dyslipidemia, everything, you are adding multiple pills. So if you can reduce the pill burden, probably that is one of the greatest thing for the patients. And the last one is, it is actually already approved in Japan, and it is discontinued in US, Europe due to cost issue, because we know once we are going for a US FDA approval, it itself takes quite a lot money significant. That's why they did not do that. Yeah. So what is the basic pathophysiological mechanisms? Main important thing, it is actually it's a DP4 inhibitors. As we know, like other DP4 inhibitors, it increases the GLP and GIP. It prevents the inactivation, and in pancreas it increases the beta cells from the insulin release and also increases the glucagon release. Glucose uptake increases, glucose production reduces. Ultimately, we know that it is effective for blood glucose control. So, if you will see what is the basic pharmacokinetics, if you will see pharmacodynamics, it is a DP4 enzyme inhibitor. Its potency is actually strong DP4 inhibition versus alogliptin, because alogliptin is another important drug where its inhibition is up to 80% even if at 7 days. So that is the beauty of this molecule, that even if at 7 days the inhibition is still persisting at 80%. And efficacy, of course, it is a very high GLP-1 level, almost 4 times, because normally we discuss all GLP-1 DP4 inhibitors, they increase the GLP by 2 times. But it increases up to 4 to 5 times of GLP level, which is much more potent. And significant HbA1c reduction, and also improves fasting insulin, C-peptide and HOMA-beta, as I have discussed, and comparison with similar efficacy in fasting glucagon, insulin resistance and HOMA-beta action. So, yeah, so if you see the pharmacokinetics, very Cmax is very high, at least at only by 1.5 hours, and elimination half-life is 19 hours after 72 hours. That means even if after 3 days, after that it takes around 90 hours, and if you take 5 times 5 T-half, it is close to 168 hours, and this is the reason why it is once weekly is prescribed. And it is metabolized by cytochrome CYP2D6 enzyme. Majority is excreted to kidney. So 76%, and protein binding is very less, close to 30%. So that is the beauty. And if you see the renal, probably it is contraindicated in severe renal failure, but in mild to moderate renal failure, it can prescribe that with a dose of 50 milligram once weekly, not the full dose 100 milligram. So 50 milligram once weekly is sufficient in mild to moderate renal failure patients. So what are the advantages? If you see that it has once weekly dosing, very simple. It is better adherence because less frequent dosing, comparable efficacy. Will show some of the data with us. HbA1c and DP4 inhibition, low pill burden, improves quality of life, also similar safety profile like other DP4 inhibitors. From the side effect point of view, from the efficacy point of view, it is almost similar, and there is no difference between that. So, if you see the DP4 inhibition and the potency of the Trelagliptin, which is highly selective, very long acting DP4 inhibitors, It is a non-covalent binding. That is, if you see probably sitagliptin, this binds covalently, but here it is non-covalent binding. Is there substrate competitiveness is reversible. It is a very slow dissociation. That is the reason why once weekly is given, very potent, up to 4 to 12 times more potent than allogliptin and sitagliptin. And it is a sustained efficacy, as Trelagliptin contributes to more sustained efficacy, and also that is the reason why we used to give once in a weekly therapies. And if you see the adverse events point of view, very well tolerated, comparable like allogliptin and others. Common adverse effects are usually nasopharyngitis, which is also seen in other DP4 inhibitors, and also another adverse event is actually some sort of pruritus, which is also found in some of the patients. And hypoglycemia is very, very minimal. It is like other DP4 inhibitors. It can be like what we in the COVID era we used to tell the safest drug is to prescribe DP4 inhibitors, even if by telephone. So it is like that. It is very safe from the hypoglycemia point of view, and in the cardiovascular lab safety point of view, probably there is no data from the dedicated trial is not there from the cardiovascular safety point of view. But of course, there are some factors like ECG, vital signs and lab tests are there, but a dedicated cardiovascular outcome trial is not there with Trelagliptin. And if you see the contraindications, as I have discussed, hypersensitivity is there. If there is severe renal impairment, it is contraindicated, and no clinical drug interaction is found with commonly used drugs, what classically we do in the clinical practice. So from the safety point of view, if you see from the renal impairment point of view, as already I have discussed, if someone is having mild to moderate renal failure, probably 50 milligram once weekly is sufficient. Those who are having severe renal failure or GFR less than 30, probably it is contraindicated. You cannot give this drug, but up to GFR above 30, 50 milligram, 30 to 60 is 50 milligram is sufficient. Above 60 is you can give full doses. You cannot, no need to change the drug. For hepatic impairment, as I have discussed, in mild to moderate hepatic dysfunction, you can prescribe, but those who are having severe grade T or child CPG grade C, probably they are contraindicated, they should not be used, but up to mild to moderate hepatic dysfunction, they don't require any dose modification because majority is excreted to kidney, so dose modification is usually not required for particularly those patients. Again, elderly patients, it is absolutely safe, can be given full doses, no dose changes or no dose requirement or no dose modification is required, no hypoglycemia is found, also no interaction with other drugs, because a lot of the time elderly people take polypills, multiple drugs for multiple diseases, usually no adverse events or no drug interaction is found any other drugs, so they can be safely prescribed in elderly patients without any hesitations. But this is the most important thing, those who are having dementia or cognitive dysfunction, they might take multiple doses forgetting the weekly dose, so that should be kept in mind, and that should be actually given some instruction to their family members that instead of weekly, if someone is taking daily, because due to cognitive dysfunction, that might create problem. That thing should be taken care, otherwise no dose modification is required for those patients. And this is the comparison of different Sita, Brida, Saxa, Lina, allogliptin and Trelagliptin and Trelagliptin. You will see that Trelagliptin is scores that comparable HbA1c efficacy like daily other gliptins versus allogliptin and sitagliptin as a directly trial, which has shown there is almost similar, there is no difference is there. And you will see again the other parameters, similar efficacy was there from the HbA1c, binding capacity, renal failure, renal safety, hepatic safety, all are actually almost similar, same thing like other gliptins, so there is no difference was found between this as I have discussed. Coming to the efficacy and safety of Trelagliptin, this is the one study, it is phase 3 study, multi-center study, Trelagliptin 100 mg for 52 weeks, and type 2 diabetic patients inadequately controlled on diet and exercise or with any of the one anti-diabetic drugs. More than that is usually they have not taken. What they found, so this is the adverse events was not much higher, it was almost similar to other drugs what is used. Serious adverse events and hypoglycemia is also similar, there is no difference was there. HbA1c reduction was a additional 0.7% was lower in comparison to those who are actually previously tested, and fasting glucose was actually significantly reduced. So that shows probably it is very good and can be safely given to the all type 2 diabetic patients with particularly only one drugs. So this is well tolerated, and weekly Tela is found to be safe and efficacious as a monotherapy or in combination therapy. So this is another study, those who are already on sitagliptin. Those who were already on sitagliptin, they were shifted to Trelagliptin once weekly. So what the point, this is that 12 weeks comparison and subsequently 12 weeks compliance follow-up study. And what they found, this is a 37% reduction in adverse events, that is, adverse event was less, their rate has come down. Usually nasofaringite it was found to be less with Trelagliptin in comparison to sita. But this is the thing, they try to six-point testing, pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner and post-dinner, blood glucose in those groups. You see, every time the blood glucose is less in comparison to sitagliptin. That means better control was found in all 6-point testing in comparison to sitagliptin. So at every point it was 6 milligram and 7 milligram at breakfast. It is 0.1 to 0.4 milligram and 36 at the post-lunch, and dinner similarly there was reduced. So that shows the probably the glycemic control is better with Trelagliptin in comparison to sitagliptin, and if you see the glycemic variability, that is also found to be less variable with Trelagliptin in comparison to sitagliptin. Again, that shows that probably 6-point testing what classically we do, that shows better result with particularly with Trelagliptin. So that concluded that a stable glycemic control was maintained, no major side effects, and once weekly Trela is switching from any version which is on any GWP4, if you are shifting to once weekly Trelagliptin, probably you are giving better results in comparison to what daily gliptins what we are using. We have a lot of trials. These are the trials, different lot of trials with Trelagliptin, and that all has clearly shown that Trelagliptin is found to be safe. It is found to be safe in elderly population. It is use of Trelagliptin has shown the improvement in the quality of life. It is the study which has shown the Trelagliptin has actually shown the improvement in the quality of life in comparison to those who are taking daily gliptins. So again, that is one of the important things. If you look QL scoring, that shows better improvement with particularly Trelagliptin. So if you see the dosing, adherence and clinical consideration, it's early DP4 inhibitors. So requiring, not daily requiring dosing is not required. So you have once weekly sufficient, long-acting DP4 inhibitors, better patient adherence. It has impact on the non-adherence, as I have discussed. Those who are having poor compliance, probably this is one of the drugs which will be a miracle for those group of patients. ADO recommendations, patient-centered approach to improve the treatment adherence. Adherence barriers are actually patient factors, dosing complexity and healthcare system issues all are there, which usually taken care if you are going to once weekly therapies, and it is approved in Japan, and weekly dosing is based on the renal function. Now it is approved in India also, it is also available in India with particularly with the 100 milligram once weekly dosing, which these people see the PK or PKPD requires dose adjustment in the moderate renal dysfunction, but for elderly people for having hepatic, mild to moderate hepatic dysfunction, dose adjustment is not required. Contraindicated in severe renal impairment, long half-life allows once daily using, and if PKPD profiles very across DP4 inhibitors, as I have clearly shown that. I think with this much I am finishing my topic. Any questions, any queries? It is everything is yeah.